So coming to eyelids, the basic anatomy, the layers of the eyelid from outside inwards are skin, subcutaneous tissue. Then there is a layer of striated muscle, LPS, Levator palpebrae superioris and Orbicularis oculi. Then there is a fibrous tissue. It consists of the tarsal plate at the center and the orbital septum in the periphery. So that's an important landmark. You should know about this orbital septum. Then there is layer of non-striated Muller's muscle. It rises from the LPS and gets inserted into the tarsus. It's an accessory lid levator. Okay. Then the palpebral conjunctiva. As you can see in this picture, first is the skin, subcutaneous tissue. Then there is a striated muscle, then non-striated muscle, and then conjunctiva. Coming to levator palpebrae superioris, it's a main elevator of the eyelids. It arises from the sphenoid at the apex of the orbit. It passes above the superior rectus along the roof of the orbit to reach the eyelid. It is then converted into thin aponeurosis. LPS splits into two layers. Superficial inserts into the lid where it forms a crease, and the deep inserts into the tarsal plate. This forms an aponeurosis. That is where all these things happen, and it's supplied by third nerve. So when there is third nerve damage, what happens is there will be ptosis. That's because levator palpebrae superioris has been affected. So this is how it is. So this is the aponeurosis. The levator palpebrae superioris muscle becomes into aponeurosis, where the superficial gets attached to the skin and the deep attaches to the tarsal plate. As you can see, the blue blue structure that is the tarsal plate. Then there is something called Orbicularis oculi. It's responsible for lid closure. Palpebral part of the muscle arises from the frontal process of the maxilla and lacrimal bone, inserts into the lateral palpebral raphe. As you can see here, there is a lateral palpebral raphe on the lateral side, and that's where the insertion happens. This is supplied by the seventh nerve. So lid closure by the Orbicularis oculi is supplied by the seventh nerve, whereas lid elevation by the levator palpebrae superioris is supplied by the third nerve. Glands of the eyelids are meibomian glands, modified sebaceous glands. It's located in the tarsal plate, but the ducts open at the lid margin. So this is basically sebaceous gland. Then there is something called glands of Zeiss, modified sebaceous gland located at the base of the lash follicle. If it's inflamed, that causes stye. Okay, Zeiss gland causes stye, pilosebaceous gland. And glands of Moll, modified sweat glands located at the lid margin between two lash follicles. So there is a mnemonic which during my entrance exam I read. It's sweaty Moll. So that makes you remember the glands of Moll is a sweat gland. So inflammation of eyelids are basically seborrheic blepharitis. It's a chronic inflammation of the anterior lid lamina involving the glands of Zeiss and Moll associated with seborrheic dermatitis and dandruff. Basically, we treat it with lid hygiene and local antibiotic steroid ointment or drops. Lid hygiene basically involves cleaning of the eyelashes as well as using hot compress and then massaging on the eyelid. Next is the staphylococcal anterior blepharitis. It's a chronic inflammation of the anterior lamina of the lids. As the name suggests, anterior blepharitis caused by staphylococcal infection. It is associated with scaling, crusting of the lid margin. The crusts on remold may lead small bleeding ulcers on the lid margin. Long-standing cases lead to madarosis, poliosis, trichiasis, and thickening of lid margins, which we will talk soon. And the treatment is lid hygiene and local antibiotic steroid. This is how it is. There is crusting, scaling here, and on removing, you will have bleeding. So basically, we have to treat the antibiotics and lid hygiene. Posterior blepharitis, otherwise called as meibomian gland disease. It's excessive and abnormal meibomian gland secretion, manifesting as capping of the meibomian gland orifice with oil globules, pouting, recession, or plugging of meibomian gland orifice. Pressure on the lid margin results in expression of meibomian fluid that may be turbid or toothpaste-like. This is how the presentation will be. This is how it is. The first image that shows the meibomian gland orifice capping, and then there is a toothpaste like material that comes out on pressure. That is how it will be. So as you can see here, this is like a most satisfying video where you press and there will be a lot of toothpaste like material that comes out. The same treatment, antibiotic, steroid ointment, and lid hygiene. Inflammation of the lid glands. Okay, external hordeolum, stye, acute inflammation of the glands of Zeiss, painful lid swelling, point of maximum tenderness at the base of the involved eyelash will be seen. So basically, sty is inflammation of the Z gland. You can remove it as S and Z, almost similar letters. And the treatment is hot compress, antibiotics, anti-inflammatory drugs, and epilation of the involved eyelash can be done. Hordeolum internum, it is the opposite of externum. Acute inflammation of the meibomian gland, painful lid swelling, point of maximum tenderness is away from the lid margin. That is the crux between the lid margin. Whether it's near the lid margin, then it's sty. If it's away from the lid margin, it's meibomian gland, hordeolum internum. And same hot compress, antibiotic, and anti-inflammatory drugs are given. This is the most important condition called Chalazion. It's very common. It's a chronic granulomatous inflammation of the meibomian gland. It's painless lid swelling. The patient just have a swelling, as you can see in this picture. The patient will have a lid swelling. It's most common the upper lid. Here the picture shows lower lid. And what we do is basically we do incision and curettage, as you can see in this picture, where we clamp that Chalazion and then we vertically incise and the pus comes out. It's basically chronic granulomatous inflammation, and all these things comes out, and intralesional steroids can also be given, but the patient is painless, and they don't have any other issue other than there's a swelling there. So even if they live for years also, it will be there and it will not cause any issues.